point, I wanted to see if there are any questions I can answer. Yes?
When you were saying soy, is that equivalent to soy milk also, or?
Yes. Well, soy milk is one of the types of foodstuffs that you could use to find soy. And that is one of the common places where it's probably easiest to get. Yes, that's an example. The question is, does stress cause hot flashes? And I think the way we would answer that is a lot of the physiologic changes that stress causes are very, very similar to what hot flashes causes. So in a lot of ways, it could take someone who has borderline hot flashes and make them worse, or it can make someone feel like they have hot flashes when in fact the physiology of what caused it may be slightly different. So that not all hot flashes are caused by deprivation of estrogen. And stress can cause a hot flash simply from the epinephrine and all the other physiologic changes of the blood vessel changes and the heart rate changes that you get at the same time. So it can be difficult to distinguish between the two.
You mentioned the hypothalamus and the loss of temperature regulation. Does that go both ways? Like
Yes, it can. Primarily because the hypothalamus does both temperature regulation of hot and cold. Although we don't know why, it just affects primarily the hot component with the hot flashes. But we do see women getting cold shortly thereafter, either from being wet or from the fact that the hypothalamus is now swung the opposite way on the pendulum and overcompensated for it. That is one of the places where I would like to see more FDA work done, because I do find the black cohosh to have very minimal side effects. I'm sure that's probably been your experience as well.
That's right.
And I don't know why there hasn't been as much done in that, except for the fact that there is so much black cohosh out there on the market now by non-FDA regulated entities, that if the FDA now goes and approves black cohosh for those things, there are so many other things that are on the market that patients would have access to without any real control over the doses. And they would almost become more problematic, because now you're saying, hey, black cohosh is great, black cohosh is safe, but you're going to have formulations out there that are not well controlled, so that it can give consumers a false sense of reassurance that it's safe because the FDA says so, even though it didn't meet the FDA's regulations and how it was produced. You know, that's one of the questions we always grimace when we hear in the office. Why did that happen? And we don't have a good answer for that. But let me ask you, were your ovaries removed at the same time?
I'm guessing so.
Okay. Well, what we have found over the last few years is that the ovaries probably produce a little bit more hormone than we once thought. We used to recommend a woman having her ovaries removed if she was going to have a hysterectomy, if she was anywhere close to menopause. 48, have your ovaries out. They're only good for 2 more years anyway. Most of the recent studies in the last few years have suggested that the ovaries still produce some low levels of other hormones, probably up until about the age of 60 or 62. And my guess would be, in your instance, your ovaries were a classic example of having some other types of hormone levels that were being produced, that when you lost those, you dropped even further. And we don't know the answer to the question for sure, but I'm going to tell you that's the way I would rationally think through it and suggest that maybe you were one of those women who had more benefits from your ovaries than you realized until you had your ovaries removed.
So now I probably have the same period of hot flashes.
No, and I would tell you, I would be a lot more optimistic.
Good, thank you.
Because I'm a guy.
Yeah.
And I think what we would find is you went from this level to this level when you were in your reproductive life to when you became menopausal. And now you probably only went from this level to this level once you lost your ovaries.
Good.
So that the drop is much less significant, and I would hope that the impact would be much less severe and for a much shorter period of time. If we're going to consider the use of estrogen, we're going to do it on the basis of your symptoms, not the FSH number. Where I find the FSH most helpful is in a woman who's already had a hysterectomy. She wasn't getting periods anymore, so we have no basis to say when she lost them. So that without that information, we're turning somewhere else to get the information as to whether the ovaries have stopped functioning, because you stopped having periods when you had your hysterectomy. That's where I tend to use the FSH mostly, and even that is more for the academic purpose of answering the question, am I or am I not? When it really comes down to whether you need to be treated or not, you're going to find most physicians want to use your symptoms as the criteria to make that decision, and not any other numbers. And I'll mention that because you're going to see a lot of other friends that may use salivary testing of the numbers to determine whether you need estrogen or not. Most physicians are opposed to using hormone levels to determine whether you need the testing or not. The answer to that question is we don't know very well. That might go back to the suggestion I said about circadian rhythms being noted in menopausal symptoms. We don't know how those circadian rhythms affect hypothalamus. I always also have you question what habits you do in the evening, whether there's any caffeine use after dinner, those types of things. And I also have you maybe reconsider how you dress when you go to bed, how many blankets and sheets you have. You're going to be more vulnerable to subtle changes in temperature when you're going through menopause and hot flashes. And even 1 extra or 2 extra blankets or sheets may be enough to take it over the top. I also see that more often in women who are younger, and you look like someone who's not been in menopause for a long time. So we do see the hot flashes persisting a lot longer in someone who's younger, simply because your body, being younger, craves the estrogen a little bit more. It was a more abrupt loss for you. And I think that makes it more difficult. As to why it's at night, I don't think I have a good answer. We like that. We use it a lot. And I think when you have a woman who's going in perimenopause, who's got all the problems, she's got the hot flashes, she's got the abnormal bleeding, and the wild mood fluctuations, there's probably, birth control pills probably come as close to anything else as we can find as the silver bullet that addresses all of that constellation at once. So that we now use birth control pills a lot to help women into that transition through perimenopause. As long as you don't smoke, as long as you don't have any other medical problems that contradict the use of estrogen, it's pretty safe. We know that the body converts other hormones that are similar to estrogen into estrogen in the fat cells, so that women who are overweight do have higher levels of what we call endogenous estrogen levels, meaning endogenous is just the hormone levels that kind of float around. So heavier women do have higher levels of estrogen circulating. It is for that reason that weight is a pretty big factor in uterine cancer risk and breast cancer risk. So I need to make that clear right now. And it was that thinking that had us believing that heavier women probably don't have as much hot flashes. However, there were studies that came out 7 or 8 years ago that showed that women who were heavier actually had more hot flashes. It contradicted everything we thought based upon the physiology I just told you and the question you just asked. So no, we do not see that. In clinical practice, we generally see some heavier women having worse hot flashes. Anyone who has any history of blood clots, either post-operative, post-surgical, pregnancy-related, anything where estrogen is remotely involved would be one of the biggest contraindications. Any family history of any other family member of having what we call hypercoagulable states, which is where you're at risk for developing blood clots. Factor V Leiden deficiency, I don't know if these things mean anything to you, as a common one. Factor S and factor C protein deficiency is another. And some medical conditions where there's already high blood pressure and the use